Good afternoon, everyone. Today I'll report a case of a large hanging eyelid angiofibroma with associated rhinosporidiosis and unusual presentation. A 34 years old male presented with slowly progressive, large hanging mass of 5 years duration, extending from left eyelid and reaching the chest region, associated with dragging sensation, diminution of vision, severe functional and cosmetic deformity. There was no history of prior trauma or surgery. On examination, the left eyelid hanging globular mass was noted, which was formed non-tender, measuring 15 cross 15 cm in diameter, with attachment of skin and soft tissue of length 10 cm. Overlying skin showed PUD orange appearance with few ulcerated points over the dependent areas. The conjunctiva was keratinized due to exposure. Rest of the anterior and posterior segments were within normal limit of both the eyes. The best corrected visual acuity in right eye was 6 by 6, while in left eye was counting finger at 2 meter. There was no preauricular lymphadenopathy noted. On imaging, there was a well-defined heterogeneously enhancing mass lesion with non-enhancing cystic spaces of size 9.5 cross 8 cross 11.5 cm with no intraorbital or intracranial extension. On angiography, there was confirmed arterial feeders from left external carotid artery, while dominant venous drainage to dilated superior ophthalmic vein. Wide excision followed by reconstruction was planned, maintaining a healthy margin of 5 mm around the tumor base. Intraoperatively, hugely dilated superior ophthalmic vessels were noted, which was ligated carefully and cauterized. Reconstruction was done with the upper lid myocutaneous advancement flap. The nasal rhinosporidiosis. 3 months after surgical debulking, the patient had a good recovery of vision and anatomical function. The patient was planned for ptosis correction and lower eyelid fornix formation in the next phase. Angiofibroma of eyelid and its histological variants are sparsely discussed in the literature. The close differential of the current case can be the giant cell angiofibroma and the fibroblastoma. However, the absence of giant cell and CD31 and 34 positivity were the differential features. Charles et al. Has described a supraciliary lesion of left upper eyelid and immunohistochemistry confirms CD34, CD163 and factor 13A positive cells. Das et al. Have also reported a rare case of extragenital cellular angiofibroma which showed CD34 positive giant cells. A definitive link between angiofibroma and rhinosporidiosis has not been established, but our case indicates a possible connection. It is important to acknowledge the rare possible overlap of these conditions, especially when the tumor is present since a long time. Rhinosporidiosis can rarely coexist with long-standing angiofibromas of the eyelid. Complete careful surgical resection of the angiofibroma can give good visual and functional outcome to the patient. The case highlights the complexity of diagnosis and management of this rare combination of pathology, emphasizing the need of careful treatment planning. Thank you.
Thank you, doctor. So did you consider the possibility of preoperatively embolizing the vessels? You saw there were dilated vessels.
They were ligated with suture.
During
They were
surgery.
hugely dilated vessels.
You didn't do a DSA and just evaluate before the surgery?
No.
Okay, what was the cause of diminished vision in your case? Like before surgery, it was hand movement.
It was counting finger 2 meter
and
due
after
to
surgery, the vision improved to 6 by 24.
because that hanging mass was dragging the eye and it was covering the upper eyelid was covering the visual axis.
So you couldn't retract the lid because of the mass before the surgery?
It was slightly retractable and the other anterior segment was within normal limit.
Are there any previous case reports like this?
No, there is no such combination of pathology in the literature.
Okay, thank you, doctor.